AIOC as well as Dr. Bharti, who's been instrumental in bringing us together and who has taken the initiative to set up this IC. This is something which doesn't interest a lot of people but is quite useful, and thanks to my previous two speakers who have made my life much easier. The sequence definitely should have been fulfilled ERG before I did my talk, but because of my prior engagements, I apologize for this change in the sequence. So, talking of multifocal ERG, I will just first try to, why do we need it? So, as we know, full field ERG is a full field or the full retina, global retinal response. So, more than 50% of the cells have to be deranged, then only you will get some changes in the full field ERG. So, focal pathology gets missed out. So, this focal pathology is very easily picked up on multifocal ERG. It was first developed by Sutter and Tran, and it not only records focal responses, but it gives you a topographical map of these focal responses as well. If we look at how it differentiates it from a full field ERG, both the responses from rods and cones are given in full field ERG, but multifocal ERG, because it is done in a light adapted condition, it gives you responses only from the cones. Then it is a true electrical response, the full field ERG. But multifocal ERG is not a true response, it's a mathematical extraction. And in the subsequent slides, we will discuss how this happens. This is just the instrumentation which the previous speaker has covered. The important thing is the stimulus. The stimulus of multifocal ERG is very different from the full field ERG where we use single flashes. Here it is an array of flashes or hexagons which is used. And this is the one which gives rise to a different kind of each hexagon gives you each trace array or a single response, and then that gives you a topography of responses. Most importantly, because here the patient is looking at a pattern, so the fixation is very important. So if the patient is not fixating in the correct place, the whole stimulus goes out of context, because the stimulus hexagons are made in such a way that the large hexagon is there for the periphery and the smaller hexagons are there for the center. But if the patient is not fixating, then all this goes wrong. Mathematical extraction goes wrong. So fixation is of utmost importance in multifocal ERG. Because fixation is important, you have to have refraction in place, and if you put refraction, you have to make sure that you don't have the rim effects. So this is the typical stimulus. It is cone driven, done in light adapted state, covers only central 40 to 50 degree of the retina, and each hexagon has a 50% chance of being on and off at one particular period of time. Though it is called that is why it is called pseudo random, because it is not really random. It is a proper algorithm which is followed. And this is the kind of response that you get. You get a trace array. Trace array means a small ERGs from each hexagon are given, and the topographical map means it gives you a distribution, that how is the reflex in the center, how is the reflex in the periphery. So you could, as you saw in the previous slide, here in this side, you have a pointer here. This side they had only 61 responses, then you had 37, then you have 103. So the number of responses can be different. So what is the importance is that if you do too many elements are checked, then there is slow signal to noise ratio, so you get a good response, but then takes a longer period of time, so the patient cooperation becomes questionable. And this is another way you can average these responses from different quadrants, from different hemispheres, from different rings, to give you this kind of topographical maps. It is also very important to know that topographical map look very nice to look at, but they take away the detail of the waveform, so they should not be really interpreted in isolation. If you talk of origin, just like the A wave of full field ERG, this N1 from the multifocal ERG has an origin from the photoreceptors and the off bipolar cells, and this also comes largely from the on and off bipolar cells with very little contribution from the photoreceptors. So this is something which, if you really go into detail, the main thing to remember is it does not only depend upon whether the given flash was bright or dark. It also depends whether the previous flash was bright or dark. That will affect the stimulation. So this is what is called kernel responses. So as in the full field ERG, if you look at amplitude, you see whether there is cell death, where the number of cells are decreasing, means amplitude will decrease. If the cells are number is the same but they are not functioning properly, means latency will increase. So the distribution, you can see here, central area is gone, means more likely to be a macular dystrophy. The whole periphery is gone, only central area is preserved to some extent, more likely to be RP. There is a generalized reduction, means here both the central and the peripheral cells are affected. Localized means here the lower area is more affected than the superior, so it gives you the distribution in the way the disease is affecting the retina. So artifacts should be kept in mind. So this looks nice, this is normal. You may think that this is also some responses are there. Actually, when you see this kind of peaked responses, this is largely electrical response, and you should look whether any electrical noise is there interfering your ERG. Here you can see that periphery the responses are better than in the center. That is usually cannot happen. Mostly this is a eccentric fixation. Patient is not fixating properly. Positional artifact, when the stimulus, the patient and the glasses are not in proper alignment, you may have some kind of positional artifacts. Just coming to clinical application, you can see both sides the retina looks similar. Full field ERG is almost similar on both sides, but multifocal ERG gives you the diagnosis. Generalized reduction, more likely to be a cone rod dystrophy. Only central area gone, more likely to be a macular dystrophy. So this is again gives you how much function is remaining in cases of retinitis pigmentosa. For central serous chorioretinopathy, we know now, because full field ERG is showing a generalized dysfunction, that it is not a macular dystrophy, and now newer imaging techniques has also shown us the same. Most important diagnostic criteria where multifocal ERG is used is hydroxychloroquine toxicity. You can see that full field ERG will remain normal throughout the period and the patient will continue to lose vision. So small area of dysfunction, this is very sensitive test for hydroxychloroquine toxicity. This is an example of chloroquine toxicity. This is why do we do hydroxychloroquine toxicity? So important that it has now got included in the screening test for hydroxychloroquine toxicity. And the important thing to remember is that these are the two tests which are of utmost importance: multifocal ERG, FAF and SDOCT. And this is the criteria which you need to remember. Any patient who's you've been using more than 5 milligram per kg body weight for more than 5 years definitely should do multifocal ERG on a regular basis. In fact, it is encouraged that the patient does it at the baseline also, because sometimes the associated disease itself may affect the retina. Desferoxamine toxicity, this is something which we had published very early on once we started doing multifocal ERG. In acquired diseases like diabetic retinopathy, you may think that we only need OCT, OCTA, but one of the most sensitive tests for diabetic retinopathy is actually electrophysiology. Even before obvious changes develop on the retina, you can have full field ERG which is down, and multifocal ERG can have changes or reduced amplitudes in specific areas of cotton wool spots or rod and blot hemorrhages. You can see even in patients without DR, you can see how the multifocal ERG is already disturbed. Increased latency, low amplitudes are seen even in the absence of any structural changes. You can, again, same example, that even patients without DR, multifocal ERG can be down. Few things to remember: whenever you do a multifocal ERG test, it does not replace full field ERG. Multifocal ERG should never be done in isolation. Definitely first do a full field ERG to know whether full field ERG is normal or not. Then only it makes sense to do a distribution, which area it is more affected and which area it is less affected. And multifocal ERG topography distribution of array is more important than absolute. So don't go by the colorful maps, look into each waveform at a specific area. Thank you so much.
Thank you, madam.
I think I've already crossed.
Yes, no. You are on time, and thank you so much for being part and for sharing your deep knowledge.